Good morning. I'd like to welcome all of you who've joined our KOL call, Challenging Landscape for First-Line Maintenance Treatment of Small Cell Lung Cancer. I'm sorry, I should have said Changing Landscape for First-Line Maintenance Treatment of Small Cell Lung Cancer, featuring Dr. Jacob Sands from Dana-Farber. My name is Keay Nakae. I'm the Director of Research and a Senior Healthcare Analyst here at Chardan. As call participants are aware, our focus at Chardan is on identifying companies that can generate exceptionally high long-term investment returns by creating shared value for society through disruptive innovation. Before we get started, just some compliance issues. During this call, we will not be discussing Chardan research. Any discussions about research should be coordinated between a participant and their respective salesperson at Chardan. A recording of this call will be made available to clients afterwards. By participating in this call, our speaker attests that they have made Chardan aware of any potential conflicts, that they will not discuss any material, non-public, or confidential information that they are aware of that may breach their legal, regulatory, or fiduciary responsibility to any parties. With that said, for anyone in our audience who'd like to submit a question to ask of our speaker, please email it to me, knakae@chardan.com, and time permitted, I will ask it at the end. So let's get started. Dr. Sands, first, welcome. Thank you so much for joining us today. And maybe to start, could I ask you to provide some introductory comments about your background and your involvement with small cell lung cancer patients in both your current clinical practice and in clinical trials?
Yeah, thanks for the invite. I love talking about this stuff, so I certainly welcome any questions as we go along and such as well. My name is Jacob Sands. I'm a thoracic medical oncologist at Dana-Farber. I'm the Associate Chief of Thoracic Oncology, and I lead our small cell lung cancer program. I have a handful of other hats, although the small cell is obviously the most relevant to this. I'll just add from the beginning that my disclosures include just about every company involved in small cell lung cancer. I was on the publication that led to the approval of lurbinectedin in the second line. I was also on the publication that led to the approval of tarlatamab, and am involved in a lot of ongoing research, although of course our discussion will maintain only the public data that exists.
Great. So, maybe to start, let's kind of further describe small cell lung cancer. It certainly is less prevalent than the non-small cell, but is known to be more aggressive. So, can you describe how the etiology of small cell lung cancer is different from non-small cell?
Well, the etiology for small cell lung cancer is largely smoking history. I mean, there are other things, it's kind of toxins, but smoking is far and away really the most common. And in the United States, at least, if someone ends up with a small cell lung cancer diagnosis that does not have a smoking history, then I dive deep into other things. Then looking at the genomics, I kind of will dive like a non-small cell lung cancer, and have in fact seen patients with actionable genomic alterations where we try a targeted therapy, sometimes with the chemo, but look to something else. So almost exclusively etiology is smoking history. Now I specify US because in China it's much more common that patients will end up with a small cell lung cancer diagnosis without a smoking history, and we can speculate about other possible reasons for that, but that can be around a third of the population there. So still smoking is common. Now, important differences between small cell and non-small cell is that small cell tends to be much more aggressive on average, tends to be very responsive to chemotherapy from the start. Immunotherapy in both non-small cell and small cell, we see patients with really durable responses, and I think may actually be curing people of their incurable disease in both non-small cell and small cell, although proportionally in small cell, it seems like maybe a little less than what we see in non-small cell. But otherwise, the dynamics are similar. Radiation, small cells often very sensitive to radiation, but it spreads more rapidly. So that whole grows more rapidly, metastasizes more rapidly in the adjuvant setting. So a stage 1 small cell lung cancer where someone gets surgery, no lymph nodes, if it's less than 4 centimeters in non-small cell, often that's it, you're done. Small cell lung cancer, even small stage 1s, we tend to recommend adjuvant chemotherapy because of the much higher risk of early spread and metastasizing. So it tends to be more aggressive But we are fortunately seeing some patients with really durable control, albeit still a small percentage.
So given the aggressive nature of it, how effectively are we screening for small cell lung cancer today?
Well, I love this question because, frankly, the most valuable thing we can do for all cancer mortality is lung cancer screening. Now, despite that, Massachusetts leads the country with a failing 20% of those who qualify actually getting lung screening. But, for anyone personally who's on this, or family members or friends, anyone who's age 50 to 80 with a 20-pack year smoking history, but just you can do these calculations online. So with a decent smoking history and last cigarette within the last 15 years, the U.S. Preventative Services Task Force recommends that those people undergo lung cancer screening, and it is the biggest thing that we can do to impact cancer mortality. Just as a brief statement of how important lung cancer screening is, and so frankly, we're failing the public with how few people are actually getting what has now been recommended for more than a decade. And there are a lot of reasons for that that I know are beyond the scope of this discussion. Now, I'd say for non-small cell lung cancer, once you get past that first scan, any of the follow-up scans, it's an 80 to 90% chance of a stage 1 diagnosis, which, as I said earlier, in non-small cell lung cancer is often surgery and done. Small cell lung cancer is much tougher because it grows much more rapidly. So even in a robust, highly functioning lung screening program, it's about 50 to maybe 60% of patients that have limited stage disease, which is often chemo radiation, followed by immunotherapy now, still with high risk of recurrence. So an area of research that I'm interested in is actually how we do screening in a way that could capture the potential for a small cell diagnosis, because even in a high functioning program, we're still not nearly as effective at catching small cell in an early stage like we are non-small cell. And that's just because of such rapid progression of the disease.
So let's dive into the treatment options, and you touched a little bit on what you might do for limited stage, but let's maybe you can describe the effectiveness of treatment options, starting with first line for extensive stage, where the current standard of care is for first line is induction with carboplatin or etoposide, and then using immunotherapy, specifically a PD-L1 today, at least PD-L1 inhibitor today, such as durvalumab or atezolizumab, followed by maintenance with the PD-L1.
Yeah, that has been the standard of care, and I'd say up until the presentation of Inforte, which we'll discuss as well. Now, that's more, I mean, that is a part of the discussion, but let's just, for clarity, we're starting back kind of before that data was released, looking at platinum etoposide and a PD-L1 inhibitor. And in some ways, I'm going to describe those separately because although we had hoped for synergy, I think what we're really seeing is additive effects. And the platinum-based therapy has been the most reliable treatment we have for small cell lung cancer. The majority of patients have excellent responses. That the scan after 2 cycles, when we compare that to baseline, often looks great. And patients and families celebrate it. And I enjoy that celebration with them of seeing the disease shrink down so much. But the platinum-based therapy we give for 4 cycles. People lose their hair, there's toxicity to that, but then they're done with it after those 4 cycles. And then, it's time to recover. The checkpoint inhibitor, the PD-L1 inhibitor, is more like a swing for a home run. It is a swing of the bat as hard as you can. And if it connects, it's knock the ball out of the park, home run, national headlines, wins the game, all of that. But the majority of times it's a strikeout. And so it's a subset of patients that get these incredible benefits from the PD-L1 inhibitors. And as I said earlier, might actually be cured of their incurable disease. That's a huge statement. And it's an unfortunately small percentage of patients. So the majority of patients, they finish their 4 cycles of platinum-based chemo, they continue the immunotherapy in the hopes that it is helping, because we can't know who it's helping and who it's not. What I've said is often, if we get to a year from when we stopped the chemotherapy, chances are the immunotherapy is working in that case, because the chemo tends to work for months, not years, just to highlight the real need in this space. If the immunotherapy works, then I have some patients that I follow for years not needing any other therapy. I have a handful of people that are more than 5 years out from when they started treatment for widely metastatic disease, and in some cases involving the brain. So huge benefit with the addition of checkpoint inhibition, although for really an unfortunate subset of patients. And to that point, we see the extended data from Empower 133, which was then called the Umbrella A study, as well as the extended data from Caspian, which is the durvalumab. And from those, we see about a 3-year survival of around 16%, but 5-year at around 12%. So low numbers, but prior to checkpoint inhibitors, that approximated zero, that 5-year survival. So this has been really big for a subset of patients, and that other 80 to 85% of patients is still where we have big need.
And up to this point, has there been any advantage to using atezo versus durva?
I give a lot of talks in academic settings as well as to the community, and I can say that across the country, and in global discussions as well, I suppose, although there are different factors that influence those. So I'll focus on U.S. But in the U.S., the decision between those almost never seems like a medical decision. It's in some practices, they're using one drug more for all different kind of cancers, and so on their formulary, they tend to focus on that one. And that sometimes is durvalumab. Other times, programs will say, hey, we started with atezo because that was the first one, and so we just continued. The exception to that is the people who kind of use one sometimes and another one another time, and but that's the minority of oncologists that I talk to. It's not typically driven by the checkpoint inhibitor data. That's really less common.
Right. So, what's prompted hosting this call is the presentation of the IMforte phase 3 clinical trial data that evaluated the combination of a former Mars drug, lurbinectedin, with atezo for first-line maintenance treatment in small cell lung compared to atezo alone. And as presented at ASCO this past June, the combination therapy achieved statistically significant improvements in progression-free survival, with the combo during maintenance extending it to 5.4 months compared to 2.1 months for atezo alone, while overall survival for the combo during maintenance was 13.2 months compared to 10.6 for atezo. So, a couple of questions here. First, what was your overall impression of the data?
So, I mean, this is a clearly positive trial, and we have to acknowledge that there have been multiple maintenance phase studies in the past that were negative. And so there were a lot of people that did not expect a positive result just because of the history of negative trials. And this was definitively positive. And so seeing that progression-free survival and overall survival, I thought was quite meaningful. Now, that is the really positive side. I think there's another element of this that I'm waiting to see how it pans out. We use the word synergy a lot, and there is reason to believe that there may be synergy in the mechanism of action of lurbinectedin along with checkpoint inhibition, particularly related to lurbinectedin's impact within the tumor microenvironment and the immune cells within that environment. And I'm hopeful for that. I think for us to conclude that there's true synergy, I'd want to see the tails of those progression-free survival curves stay apart. Right now, it looks like they come together, but we don't yet know, because really the time, the median follow-up of this was around 11 months. And so that tail of the curve is really well beyond those 11 months. So that really may evolve quite a bit further. I don't think we yet know what the tail is really going to look like. But on the other side of that, on the overall survival curves, those tails do seem to stay apart. Now, again, we're going to have to wait and see how that evolves. And so what is the truth of this? Are the progression-free survivals curves going to mature in a way where they actually do separate out? We do see a plateau that is above the control arm. That would really be quite encouraging. And I think if there's true synergy, that's something that I would expect to evolve out. And maybe we're getting a hint of that from the overall survival curves, and that they are separated out. I don't know. I mean, I can't draw conclusions, but that's something that I'm watching for from this. There is more toxicity to this, and so that is the balance in all of this. I can say by and large, the patients that I treat on lurbinectedin, which has been my second line standard, up until recent data. And so this is uh, certainly a better tolerated drug than the other cytotoxics. There are some patients that do have severe fatigue and occasionally severe nausea. Those are not, these are low in numbers, and it reflects that in the toxicity profile as reported from Inforte. But aside from some of these less common scenarios, many patients tolerate it quite well. And so just as a first look, for everything, the balance is what are the benefits and what are the toxicities. And so that's kind of a quick overview of some of my initial thoughts.
And so, this is a question we get all the time because we're looking at different oncology drugs and looking at the outcomes. And maybe it'd be helpful to give your perspective on what's the impact of extending survival, in this case during maintenance, by a couple of months, let's say, in the treatment decision by oncologists such as yourself.
So I get these kinds of questions all the time, and especially in the consulting with companies that have ongoing trials, and they say, "Hey, when the data comes out, what are you looking for? What's going to drive use? Is it the progression-free survival, overall survival, toxicity? What's meaningful to you?" I struggled with how to answer that because the answer is far more complex, and I'm kind of describing something. So if it's okay, I'm going to share my screen and show you something that I've put together as a way of answering these questions and to, I think, help describe clinically what physicians are, what their equation is around any of this. And I'll tell you too, I have presented this concept in conferences, and I have had a number of physicians come up to me afterward and say, that was a great way of explaining what we are often, what our equation is. So hopefully this helps. Overall survival absolutely matters. But there is no one factor that matters alone. So what you see here are 6 different factors that I've come up with. I mean, these are kind of the obvious ones, I suppose, but for value of a drug. And if it's just a way of comparing drugs, this is anyone can create this subjective equation, so to speak, but you'll be able to see it in a 2-dimensional image. So at the top there is the median overall survival and going around clockwise, progression-free survival, the dosing schedule, which is a time toxicity, duration of response, toxicity being the side effect profile, and then response rates. So each of those matters, but not individually. And if you think of each of these as a score from 0 to 5, where 5 is the best, if you rate each of those, now I've created an example here that hopefully will, here we go. So here's an example. So first line, carboplatin etoposide. And I didn't, whether the score is exact, I mean, this is for demonstration. So very good response rates. I mean, platinum etoposide, the most reliable responses we get, but, the overall survival is not amazing. I mean, platinum etoposide is really around 10, 11 months. Progression-free survival, maybe slightly better than overall survival, but that's, small cell, you have disease control and then patients die when it progresses. Dosing schedule, pretty decent. I mean, 3 days in a row isn't so convenient, but 4 cycles and then you stop. So, call it a 3. Duration of response is pretty limited. It works for months. It is quite toxic. Patients lose their hair, which I think is a bigger deal than many want to say. People think of caring about losing hair as an issue of vanity, when in reality, it's also how you see yourself in a mirror. Now, I'm highlighting that because the Inforte regimen, I think this is an area where there's a real strength, where you're giving a cytotoxic where people still, their hair comes back. And there's real value in that. Again, beyond vanity, people who have lost their hair look in the mirror and they see themselves with cancer, as opposed to those who, when they first get up in the morning and look in the mirror, they're not immediately hit with the fact that they're on chemotherapy. And then response rates are quite good. So if we say that's platinum etoposide, now you add in a checkpoint inhibitor, well, the duration of response is substantially better. Toxicity is minimally less. And you can see, the overall survival and progression-free survival are not overwhelmingly different. And the dosing schedule is a bit worse because you're then continuing something beyond those 4 cycles. But I think that's a clear advantage. And so to look at any one factor in itself is really limiting all the other aspects. Now, hopefully this is helpful to everyone attending in that you can actually take the data from different trials. And you can create this yourself and scoring each of the drugs and then getting a sense of, okay, how much is the physician going to really value this one over the other in a multidimensional way instead of just looking at each one factor itself.
Well, great. Yeah, that's a very helpful way to think about it. Um, so I guess, the follow-up question to that is, we're not that far away from this drug becoming available in the US. Jazz Pharma, who's the co-sponsor of the study, which has the marketing rights to PharmaMar's Lurby in the US, has submitted an sNDA to the FDA for this indication with a PDUFA date of October 7th. So based on the data, how quickly do you think oncologists will adopt the use of this combo once approved?
Well, the benefit is that people are already familiar with this. I mean, this has been a second line preference for a lot of oncologists. So it's moving a drug that they're familiar with into the maintenance setting. Now, there's a balance in this. I would expect it to be used widely early, the degree of which will probably vary from oncologist to oncologist based upon how frequently they're using it right now in their standard of care practice. But those who are using it in the second line, I would expect to be to more quickly then move it into the maintenance setting for use. But this is probably something that by and large will be a discussion with each patient. There will be practices, I expect, where people are going to widely adopt it for everybody. There are going to be other practices where they may not use it, and that would likely be centers that just right now aren't quite, haven't adopted it as much. But we've really had quite a bit of time for this to be adopted in practices already and for people to have experience. So I don't expect that for a lot of practices either. But I am often surprised by the data that comes out, even in like frequency of genomic testing for non-squamous non-small cell lung cancer. That is an unarguable standard of care, and that unfortunately doesn't happen for everybody. So there are always going to be some physicians that their practice, for whatever reason, hasn't quite caught up, I suppose. But more commonly, I expect people in between, where they're going to be evaluating each individual patient. Is this a regimen that makes sense for them? And they will be adopting it quickly within the context of each individual patient. And to that point, there are practices that are already doing this. And I'm already having these conversations with patients. And this is a drug that is already available and doesn't require an FDA approval to start prescribing it. And so this could be used off label. And so I'm already having those discussions.
Interesting. Another factor in the rate of adoption of oncology therapeutics is the inclusion of that therapeutic option in the NCCN guidelines. So as a member of the guidelines panel, can you describe the process of how the NCCN guidelines get updated?
Yes. And I want to clarify something because I've been asked a lot about this. Right now, the NCCN guidelines give an indication of an update from like July of this year, but that does not incorporate the data from ASCO. Actually, that's from a meeting that was prior to ASCO, and so there will be updates to the guidelines. That process, I don't know where that is, and I don't know. I guess I'll leave it at that. But generally, the way the NCCN guidelines process happens is there are regular meetings that we have, but those are not always timed in the best way. It's just maybe by chance. But as I said, the last update comes from a meeting in May, and then when there are big developments that change the standard of care, then there are kind of ad hoc discussions or voting that goes on. And then to in an effort to kind of catch up to those changes in standard of care. And so it's hard kind of coordinating everyone's schedules and then getting all those votes, I imagine, and making sure they've gotten from everybody. And so there is certainly a process to it in both respects: regular standing meetings, and then trying to keep up with things that are outside of those regular meeting timeframes.
I guess just maybe two questions to follow on to that. Number one, have you had any ad hoc discussions about the combo for maintenance since Inforte was published back in at ASCO?
I'm not sure where the line is on what I'm allowed to say in the NCCN guidelines process. So I'll leave it at that and just saying
That's fine.
that the last
Um,
update is pre ASCO.
So a second question would be, assuming once you have the discussions, and everybody's maybe signed off on changes in the guidelines or an update in the guidelines, do you wait to publish that until the drug is actually approved for that indication?
I don't know. So no, not necessarily. The drug doesn't have to be approved for the guidelines to be updated. There are things about the guidelines. Going back to lung screening, I sit on the small cell committee for NCCN. I also sit on the lung screening committee for NCCN, and I'll highlight that there are screening recommendations that actually go beyond what the USPSTF recommends, and so the NCCN guidelines are not beholden to those approvals. I think they factor into discussions, of course. And if something is approved, then I think you can really anticipate it to be on the guidelines. But the guidelines are really meant to be a statement of what is not just recommended, but even treatment options that one should consider, even if not approved. And actually, to that point, the small cell guidelines in the second line setting includes multiple drugs that are not FDA approved, although commonly used in irinotecan, paclitaxel, temozolomide. These don't have official approvals, although these have been used for quite a long time. So we want to make sure that we're putting out there what we personally are doing for our patients, and not just stamping approvals as they happen.
So maybe just to sum this part of the discussion up, how important is it for a new therapy and indication to be included into the NCCN guidelines? What do these guidelines, whose decision making does this really drive?
I think this matters a lot more for the community. Now, academic centers use it as well, I'd say, especially junior faculty, as they're kind of getting a sense of what is considered the right treatment. This is a group of people that are identified as experts in the space coming together and saying, okay, the culmination of all of this data, here's how we distill it down into our practices. And I guess when giving talks and such, I really try and at the end kind of say, okay, all that information I presented, here is what that means to me, and here is my practice. And the NCCN guidelines are intended to be that last conclusion of here is our practice and how we choose to prescribe these regimens. And there are disagreements amongst members of the committee. I think sometimes it comes across as if it's all unanimous. But there are different perspectives, certainly, and that gets distilled down to, okay, what is the most common thread that everyone feels comfortable with? And so there are nuances possibly, but overwhelmingly, this is how many of us are practicing with slight variations. For the community where they're not seeing a lot of small cell lung cancer, this makes it very easy for them to just log in and follow an algorithm and say, okay, well, the next treatment that should be considered is this, and then having a reference to that journal article. Those that are focusing in the small cell space, kind of know all of it and maybe are aware of what's on the NCCN guidelines, but maybe not as personally driven by it.
And let me just go back to how this might impact how you responded to that earlier question about using Atezo versus Durva. With the Inforte data now out there with a pending approval, given that there might be some nuances to why a center might up to this point have chosen to use Atezo versus Durva. If you have it now in the guidelines, does that change those practices in your mind?
Sorry, if you have what in the guidelines?
That the preferred treatment for maintenance is the combination of Atezo plus Lurbi.
that given that you have sorry, you're saying atezo, lurbi, that with tarlatamab, would that change the checkpoint?
Yeah, sorry, just to be clear.
Okay.
In the maintenance setting going forward, if the guidelines now recommend atezo plus lurbi, does that change the practice of those centers that currently were choosing to use durva versus lurbi for, maybe other institutional reasons?
So we'll see. I would anticipate that most will preferentially use atezo because that's how the study was done. I've kind of asked about this, in various discussions, both with community oncologists and with academic colleagues, tried to kind of push people on this to just get a sense of sentiment. I'll tell you that I don't personally feel like there's a huge difference. And if someone says, "Hey, if I've been giving durva, then I'm going to continue durva with lurbi," okay. I mean, I think that's fine. What I'm hearing is I think many are more concerned about the possibility of difficulty with insurance or something like that, and frankly, that does sometimes drive the decision making of some of these. And so I think it's more common that people would be giving atezo, and even if they've started with durvalumab, there are some who worry that insurance would end up not covering it if they've started treatment on durva. Although I don't, I think it'll end up being covered anyway, and that one could then switch, and I think that's fine. I mean, I guess on the medical side, I don't have reservations about this. On the insurance side, possibly from one insurance to another, there can certainly be variations, and that ends up sometimes being a hassle of practice that goes beyond the medical decision making. But I think these are fairly interchangeable.
Okay. Well, maybe, some of these questions will be resolved once we see results from the ongoing Delphi 305 phase 3, which, similar to Inforte, is evaluating the combination of Amgen's bispecific T-cell engager, tarlatamab, plus durva, compared to durva alone as first line maintenance. So what's your expectation for how this trial might read out?
So I'm optimistic about the trial. I mean, the early data that we just saw from the phase 1b at World Lung was impressive, with a 25-month overall survival. So now that's not a randomized trial. The 305 is the randomized trial, and so I'm optimistic about it. But we have to wait and see what the actual data shows. We certainly have examples of single arm phase 2s that don't pan out in the way we expect in the phase 3. But this drug has been revolutionary in itself, and the data we've seen thus far has been impressive. And so, I'm waiting to see then how that randomized trial shows, what that randomized trial shows. And once we have that data, then we can discuss how that impacts decision making as well.
Okay, great. Well, maybe we can talk a little bit about second line treatment. Lurbi, as you mentioned earlier, since its approval, has kind of quickly emerged as the preferred second line treatment. And can you explain why this was the case?
Yeah, small cell lung cancer has really suffered from limited effective therapies. And in the second line setting, is where I think the toxicity profile actually matters quite a bit. So up to 2020, we were looking at topotecan, or in my preference, irinotecan, as a second line treatment. Now, second line therapy, topotecan was approved in a failure versus CAV. The curves completely overlap each other, but topotecan had better symptom improvement and less toxicity than CAV, which is saying a lot considering that topotecan is something that's quite toxic in itself and that sometimes people refer to as topotecant. Now, that's why I prefer irinotecan, because it has less of a toxicity profile than topotecan. I'd say time toxicity, it's not the 5 days in a row, it's day 1, day 8, every 3 weeks is how I prefer using it. And so it's a less toxic regimen. But all these chemotherapy agents, when they're working, it's typically for months, not years. And lurbinectedin, although the median progression-free survival was not inspiring, the overall numbers are a step forward. I mean, when you compare that to the other chemotherapy agents, it appears to be a step forward. Now that's cross-trial comparisons, of course, and so hard to draw definitive conclusions from that. But if anything looks better than what we see from other cytotoxics, and very importantly, the side effect profile is clearly better than what we see from some of the other cytotoxics. So a once every 3-week dose that many patients tolerate well. I've highlighted, I mean, to be fair, I've highlighted that there is a subpopulation that really does not tolerate it. And there are people where I have stopped lurbinectedin despite efficacy. And in some cases, I mean, one of the more extreme cases comes to mind of a guy where I stopped it because of really terrible fatigue. And he had one of the more aggressive small cell cases I've ever seen, and had an amazing radiographic response to lurbinectedin, and then still had 4 months of ongoing disease control even after stopping lurbinectedin before his disease started growing very rapidly again and was resistant to everything. And so there's a balance in this of the efficacy being what looks like a step forward and the toxicity comparing quite favorably to the other cytotoxics. And in that setting, that toxicity profile matters a lot. If you're not going to be able to control the disease with real durability overall, then you want to make sure you're not really knocking people down in the process.
So the next set of questions kind of relates to how second line treatment might change. I guess the first question within that is, how has the introduction of tarlatamab, is that changing the treatment landscape for second line in your view?
Well, I'll be clear in that I think from Delphi 304, the randomized trial of tarlatamab versus chemo, that tarlatamab is the definitive second line standard of care. Now, that being said, there are complexities to giving tarlatamab, and unfortunately, this is not available at most programs throughout the country. I see a number of patients referred from the region to see someone and talk about tarlatamab, and in some cases then to start their treatment here. And still to this day, many of those patients have to make the trip here if they want to even continue it. I've really advocated that centers make this available, at least starting in cycle 2, so that patients can start their treatment at some center that allows for that, and then transition back to a closer to home environment to get the drug. But that is not the case still in much of the country. And so although I think the data is compelling for the second line, that doesn't mean that it's widely available to every patient. On top of that, there are real complexities that are the reason for that. It's not just a matter of drug availability. It's centers feeling comfortable in handling the cytokine release syndrome. That's about 50% of patients. I'd say the majority of those cytokine release syndrome are these are easy to handle. I mean, it's not a problem for the majority of patients, but the problem is identifying the subset of patients where it is a real problem. And so although there is discussion about doing this all in the outpatient setting, we're just not there yet. There are some centers that are doing that, but they often have an infrastructure in place that's not available at many other places. And so, I'm maybe glossing over a big topic here for the sake of time to say that there are real complexities about giving tarlatamab that have limited its second line availability despite the strength of the data in that second line.
So again, if somebody were to evaluate this in your hexagon decision algorithm, the areas of the two curves where the efficacy may be balanced by the complexity, do you see that kind of ending up a similar area, or how does that shake out in your hexagon?
Well, I think with tarlatamab, we see better toxicity and better durability. So the strength of the data is there. But the cytokine release syndrome element of that, which is in the toxicity, people might score that differently. And this is where this is a subjective scoring for everyone to weigh out. And I think those without experience with tarlatamab are probably going to score toxicity as much more challenging than the centers that have a lot of experience with it. But, part of that is being in a center where there are a lot of people who have that experience. When I admit a patient to get this drug, there are physician assistants and staff and nurses in the hospital that have a lot of experience with that. If you were to then put me into that community-based setting where I'm running my practice and the patients are getting admitted to hospitals that are not really where my practice is and being cared for by staff that aren't as familiar, that ends up with a completely different experience. And so this is going to vary from site to site. But I think in the hands of centers with experience, the data is strong for tarlatamab, but the logistics are still something that is going to require more work. So it's not yet widely available, despite the strength of the data.
And then again, if Inforte and the combination of Atezo and Lurbi is extending those on maintenance, the people that eventually fall out or just don't take to that combo, how might that affect treatment decisions for second line?
So it sounds like what you're addressing is, patients that may end up not getting a second line therapy. And so does that influence kind of this escalation of their maintenance setting care? And that's a really important question to this. The numbers that are often quoted is about 50% of patients that end up not going on to second line therapy. Now, I'll admit, I feel like I have more patients that do go on to second line therapy. Although, I am in a highly specialized practice with a whole bunch of support staff that is also specialized and such. And I hope that our practice is not what fits the median practice overall. So this equation may vary from site to site as well, but certainly varies from individual to individual too. I mean, there are some individuals where maybe you can anticipate that this is your shot, and others where it can be harder to say, but you can be surprised by each of those. But that's the equation, is in each patient that you see, one, if they have progression, are you going to catch it early enough that you're able to intervene? But the other part of that is that by intervening earlier, are you also preventing some of the more rapid decline that can occur? Are you actually altering the disease in itself in some way? Are you preventing the generation of new resistant clones for some time frame? And so that's something that we'll have to monitor as well. There's progression-free survival curves and the overall survival curves. There's not one of those alone that tells the full story. Some of this is piecing those together. And in some cases, you have progression beyond, you have an initial progression event, but something you can address. For example, on lurbinectedin, if someone has a new brain metastasis, but otherwise ongoing disease control, radiate that spot and then continue maintenance setting. I think that's relevant actually for a lot of scenarios. I'd say even just the checkpoint inhibitor, if there's a new spot in the brain, radiating that and then continuing therapy. So on your progression-free survival curves, that's still going to show up as progression, but kind of the overall value to that person or duration of disease control may even go beyond that further. So it's an individual kind of assessment for each patient as well.
Somewhat lost in the excitement over Inforte is we still have this ongoing phase 3 Lagoon clinical trial in second line setting, which is evaluating Lurbi as mono versus Lurbi in combination with irinotecan versus a control arm. Is there a specific piece of data that you will be focused on when we see the outcome of this study?
So going back to synergy, I mean, we have a single arm phase 2 of the combination that really looks compelling. Now, we use that word synergy a lot, and there are various examples of combinations that we had hoped for synergy, but then didn't really see data that suggests it. But in this, we have data that really looks like there's potential synergy. And of course, there is, there was a hypothesis around that from the start that prompted the combination. So I'm really hopeful that from that combination, we'll see a greater efficacy signal than even then related to the lurbinectedin alone. As far as lurbinectedin versus the control arm of either irinotecan or topotecan, the lurbinectedin has been my preference. And at a minimum, I would expect a toxicity benefit. I would love to see an efficacy benefit as well that comes out in the data. This is a very difficult disease and is resistant, and this is where I commonly hear people say, "Oh, nobody likes topotecan, but they don't beat it." And I say, well, topotecan didn't really beat anybody either. This is a hard to treat disease, and so we'll have to see where that shakes out. But I'm really hopeful to see something from the combination in particular.
Great. And maybe just a final question or two. The first one, just kind of looking forward. Are there other novel clinical stage therapeutics that you think have potential to be effective in the treatment of small cell lung cancer?
There's a lot going on right now. We could have an hour long discussion and it wouldn't feel adequate with this. So I'll just broadly state that I think there's more going on right now in small cell lung cancer research that's promising than the culmination of everything to this point. We're talking about drugs that might actually replace platinum etoposide in the first line setting ultimately. It'd be years before we got to that point, but that was unimaginable to me a few years ago and now seems really potential. We have classes of drugs with antibody drug conjugates, the radioligand therapies, as well as other immunotherapy agents, CAR T. There's a tremendous amount going on, and so academically, this is a very exciting time. And I think we've seen some real steps forward up to this point. When you think about the lurbinectedin approval in 2020 was essentially the first second line step forward that we'd seen in many years. And now we have a handful of other things in development that I think have real potential. So I think in the next 5 to 10 years, we're going to see changes in the field that were really hard to imagine 5 years ago.
I mean, maybe just a final question, but in tandem with that, for non-small cell, we've seen the emergence of all these targeted therapies based on genomic subclassifications. What's the prospect of that, that we might see subclassifications in small cell lung cancer going forward?
Academically, there's a lot of focus in this, and it is exciting to see that. I think the subtyping is not nearly as clean as it's often presented. It's kind of presented as these very distinct subtypes, when in fact, those subtypes are really more which one is more prevalent than the other, but there's often a mix in these as well, and there's some plasticity to them. We haven't yet seen anything that would really drive clinical decision making. But what's exciting is that it sets a foundation upon which we're building toward potentially being able to treat cancers in a more focused way. And so there's currently the PRISM trial. This is a SWOG first-line study using different regimens in the maintenance setting based upon these different subtypes. There was a previous SWOG study that looked at schlafen-11 expression and added a PARP inhibitor. And so this is a demonstration of the fact that we are able to enroll a maintenance study, but that study was negative. And, although we do see hints of better identifying which subtype might benefit more from, for example, immunotherapy in the maintenance setting, when looking from the Empower 133 and the Caspian data, the inflamed subtype seems to benefit more, but the other subclassifications also benefit. So it's not something that would drive clinical decision making yet at this point, but it is an important foundation to build upon, because frankly, we are going to need much more from the biomarker work to really change the field. We've had such advances in the therapeutics that now in the next 5 years, I'm really hopeful that we'll see some big jumps in biomarkers that'll help us sort things out a bit better, and which therapeutics might be better for which subtypes. But that is really ongoing work. I wish we were further along than we are. I think it's often presented in a way to suggest we are further along, but we do have the foundation to build upon, which I do think is exciting.
Well, great. Well, we have reached the end of our time here. Dr. Sands, I want to thank you so much for joining us today, as well as thanking the members of our audience who joined us today. We will have a replay available maybe in a day or two. So with that, we'll call a wrap to this. But thanks everybody for joining us today, and have a good rest of your day.